Well, hello again, everybody. Thank you so much for joining us. Again, my name is Marie Stuckey. I am the Member Relations Specialist at the Maine Health Management Coalition, and I'm happy to have both our members and non-members listening in today for data member medical and pharmacy trends and comparisons. Before we start, just a little housekeeping. Everybody is muted, but we will take questions at the end of the presentation. So anytime you have a question pop into your head, just type it into the chat box, and we will address them at the end of the presentation. This is being recorded and will be available on our website, so you can always get access to it later on. And this particular webcast does earn you HR credits, and if you're interested in those, you can email Trevor Putnocki, our communications manager, at tputnoky@mehmc.org. Okay, so just to give a little bit of overview to non-members who are listening, we are a multi-stakeholder group. We're employer-led. We have about 74 members who, in addition to employers, comprise health plans, providers, consumers, and affiliates. And our mission is to improve health and maximize improvement in the value of healthcare services for all Maine residents. We accomplish this in several ways. One is through our consumer website, Get Better Maine, where we have public reporting on providers in terms of their effectiveness for patients, their safety, and the patient experience. We're very excited that we've just recently added behavioral health as a specialty to this website, and in 2015 we'll really be growing substantially with the addition of oncology, orthopedics, cardiology, ophthalmology, and maternity. This initiative is supported by the Robert Wood Johnson Foundation. We were one of 10 community healthcare alliances selected to participate in the Doctor Project, which is a $1.3 million project that helps consumers better understand and assess the quality of healthcare provided by local physicians so they can make a wise choice in who gives them their care. This project will support publication of our provider findings in consumer reports in 2015. Another way we accomplish our mission is through value-based insurance design, which is a revolutionary new health plan that provides patients with information about the cost and usefulness of services at the point of care. It results in high-quality care at the most reasonable cost through evidence-based care, and streamlines administrative practices that currently are costing practices nearly $86,000 per provider. We're very pleased to be in development with all the health plans in Maine to make this available in the last quarter of 2015. And for some details on the plan, I would encourage you to look for registration for a webcast on this in March 18th. We are diligently working on our February webcast, and we'll be determined shortly, and we'll announce that to you. And then, as you can see on the screen, is the, again, March 18th date for the value-based insurance design. Like this webcast offers, there'll be some others that have credit hours available, and we are pleased to offer the webinars free to our members. Some non-members will have to pay for certain webcasts. Another initiative that we do to advance our mission is to have events where people can network and learn from each other, and we just recently had a wellness event in Orono called Saving Money with Workplace Wellness. That was co-hosted between the Coalition and the Wellness Council of Maine, and included presentation, panel discussion, and dinner. There are other opportunities for involvement that you can certainly participate in, and we encourage that through our work groups and committees. We are working on some roundtables between providers and employers, and we'll get information out to you as soon as we have dates. And of course, we have our annual symposium, so look for a date for the fall of this year on that. Here's just a list of our current members, and if you would like this, it is available on our website, or you can certainly have this slide if you would like as well. So if you're interested in supporting the work that the Coalition does, please contact me. My phone number is right there and my email address. We would love to have as many people on board as possible. And now I'm happy to introduce our presenter today, Sarah Fitzgerald. She joined the Maine Health Management Coalition in April 2012 as the Employer Reporting Manager. In this role, Sarah is responsible for working with employers and their carriers in order to incorporate historical and ongoing claim extracts into the Coalition's database. She's also charged with developing standard reports that detail a plan sponsor's demographic, spend, cost sharing, and utilization trends compared to Coalition benchmarks. For members with enhanced data memberships, Sarah creates custom reports and analyses to address specific business needs. She is a graduate of Cornell University, where she majored in plant breeding and genetics, and Yale University, where she received her master's degree in public health. Prior to joining the Coalition, Sarah managed a team of healthcare analysts at a care management firm in Portland, Maine. And I now will pass over to Sarah. Thank you.
Thanks, Maureen. All right, so I'm just going to quickly go over our agenda for today. We're going to very quickly, for those of you on the phone who are not familiar with the data program, we're going to give you a quick overview of the scope of our data program. We are also going to dive into medical trends by plan sponsor, and here we're going to really focus on the allowed per member per month expenditure in terms of cost. We're going to look at resource use, which may be a new concept to some of you that I'll explain, and then we're going to look at a price index. We are also going to examine a case study that we used for one of our employers here, so looking at how to use the total cost of care and resource use measures to determine whether costs are being driven by utilization or price. And then if time permits, we'll look at a little bit of pharmacy trends by plan sponsor, and then also cost sharing trends by plan sponsor. I have graded those two items out because I'm not sure that we're going to have time to get to them. But as Trevor or as Marie mentioned, this entire presentation will be available for download from our website after, in case we don't get to those sections. So if you, on the current slide, you can see really where we're going to be focusing today is within that kind of blue piece of the pie here. We are building a complete claims database that incorporates employer commercial claims, statewide commercial claims, and then public payer claims, both from Medicaid or the MaineCare program and from Medicare directly. The data member feeds is where we're going to focus today, and those are feeds that are sent directly to our vendor, HDMS, by the carriers that each of the plan sponsors uses. And those are used for employer reporting, benchmarking, and also some ACO work that we do for a couple of specific plan sponsors. You can see that we also do have access to the statewide commercial claims. This is the Maine Health Data Organization commercial claims data feed. It's de-identified data, and we use this for cost and quality reporting and also to evaluate some of the PCMH pilots. As I mentioned, we do have identified Medicaid or MaineCare data feeds as well coming into our database, and this is used to support a lot of the SIM grant work and some of the ACO projects for the accountable care communities. And then in progress are the Medicare feeds, which will be identified data as well. So currently the data program supports 22 employers, and these employers really kind of span the a breadth of different industries. So we have employers who represent the healthcare, manufacturing, insurance, research and development, public and educational sectors. The plan sponsors we have incorporate a large statewide geographic presence. They represent all of the major carriers. And currently we have 5 years of historical data across most plan sponsors. And new claims feeds do come in and are incorporated into the database on a quarterly basis. So within the current report that I'm going to be going over today, we have included 19 plan sponsors. Not all 22 have been incorporated due to data issues with a couple of the plan sponsors. We'll see that data has been blinded throughout the presentation in order to protect the confidentiality of the individual data members. But if you do see that your organization is within the list that I've included here, and you'd like to know which letter you've been assigned throughout the presentation, you can feel free to email me after the presentation, and I will let you know. So the reporting methodology we're using today incorporates 4 different 12-month periods. They span July through June of each year, and each of the periods includes 2 months of claims run out, and so we can compare the costs that we're going to see and the resource use across those time periods. We do make some adjustments to the data across the plan sponsor so that we can get the best comparison. So we exclude members who are under age 18 or over 64 years of age, so we're really just looking at an adult population here. We exclude individuals living outside of Maine, anyone who has Medicare supplement coverage since we don't receive their full claims. High-cost claimants are also excluded, as are members with fewer than 9 months of eligibility during a 12-month reporting period. And finally, we also exclude behavioral health medical claims because we do not receive those consistently from all the different vendors. So you can see that the study population here that we've included in this report is fairly stable over time. There's been a little bit of a dip in subscribers in that most recent time period, same with members, and this was due to a couple of plan sponsors changing their health plans and being incorporated into a larger plan sponsors database and not meeting that 9 months of eligibility criteria. So now we're going to take a peek at medical trends. And the current slide shows actual or raw PMPMs across those 19 plan sponsors that were included in the report. So this is in aggregate. And I should mention that all the reporting we do is on an allowed per member per month basis. So this incorporates both what the plan is paying towards the claims and also any member paid amounts in terms of co-pays, co-insurance, or deductible amounts. We're not reporting anything on premiums here, so this is just claims data. So in aggregate, we can see that the raw PMPMs have really leveled after years of sharp increases. We can also see that pharmacy expense is growing faster than medical spend. The yearly change column there represents the average yearly change between those four reporting periods that are displayed here. And the yearly change column all the way to the right, based on the total population, you can see that those numbers are just a little bit higher. Those numbers do include high-cost claimants, pediatric members, retirees, and members who have fewer than 9 months of eligibility. So you can see that once you do add those members back into the total population, the pace of spending growth has been a bit faster. This next slide looks at medical per member per month trends by plan sponsor. So here we have risk adjusted the allowed amounts. Again, we're looking at both what the plan is paying and what the member's paying in terms of the overall amount remitted to the provider for the services rendered. So because these are risk adjusted, the cost differences that we see here are not due to underlying health status of the population. So this really allows us to compare all of the different blinded plan sponsors which are across the bottom of the chart there. So each of the 19 individual plan sponsors is represented by a letter at the bottom of the chart. This particular chart is sorted by lowest to highest medical allowed PMPM in that last reporting period, which spans July of 2013 through June of 2014. So just a couple of notes here, just in terms of helping to interpret some of this data. If we look at plan sponsor Q, for example, this is a plan sponsor that has moved largely to a higher deductible plan offering during the over the reporting periods here. So you can see that that has had a bit of an impact on their spend from prior periods. The same is true for plan sponsor B. So you can see that that's had a pretty dramatic effect on the total allowed medical PMPM. So on the next slide, this is the same slide as the one before. If you recall, on a prior slide, I had talked about how we do have access to the full commercial book of business data from the MHDO. And so this is the same slide as the previous one. The only thing that's different is I've added the MHDO average allowed medical PMPM in the most recent reporting period to the chart. So you can see that the MHDO book of business average is slightly lower than the aggregate average for the 19 plan sponsors included in this report. So for those of you who aren't familiar with the concept of resource use, we have implemented the Health Partners Total Cost of Care and resource use measures within our Pathways to Excellence program for public reporting on cost and resource use at the practice group level. So we can also use these same measures from a purchaser perspective in employer reporting. So resource use really measures both the quantity and the intensity of the medical resources that a particular plan sponsor is using. So on this slide, all plan sponsors have been indexed to the main health management book of business average in 2014-06, or June of 2014, so that you can easily see whether a given population is using more or fewer resources than the average. So just to be clear, if we look at plan sponsor D, for instance, we can see that in all time periods, that plan sponsor is using fewer medical resources on average than the aggregate MHMC book of business. And if we look at plan sponsor A, we can see just the opposite is true, that plan sponsor A is using more resources or more intense medical resources than the book of business average. And again, these are risk adjusted, so the differences that we're seeing here are not explained by any differences in health status in the underlying population. One other thing I wanted to mention here is that the MHMC average, which is our book of business for those 19 plan sponsors, as well as the MHDO full commercial book of business average have been included here. You can't see the MHDO average here because it's right underneath or right on top of the MHMC average. We'll come back to that. We'll come back to that in a minute on the next slide. So when we use the allowed per member per month and the resource use PMPM together, we can calculate an overall price index for medical services. And so the math there is right kind of at the bottom of the slide. So the price index is calculated by dividing the allowed PMPM by the resource use PMPM. And again, here the plan sponsor data and the MHDO average have all been indexed to the MHMC average in the June 2014 reporting period, so we can easily see which plan sponsors are falling above the average in terms of the medical price index. So recall that we had looked at the allowed per member per month expenditure for the MHDO book of business, and we'd seen that that was lower, slightly lower than the MHMC average, but we also saw that resource use PMPM were kind of one and the same. Here we see that the MHDO average for the medical price index is slightly lower than the MHMC book of business average across the 19 plan sponsors. And this is really telling us that on average, the full commercial book of business is using about the same number and intensity of medical resources as our MHMC book of business plan sponsors, but that the MHDO average, the MHDO population is paying somewhat less for those services. And when we look into why this might be the case, it appears that the MHMC book of business has slightly more of its membership weighted towards higher cost regions, so sort of towards northern parts of the state compared to the MHDO full commercial book of business. Okay, so now I want to show you how we can use the cost and resource use measures together to help a specific employer determine what's driving their cost. So we're going to look at a pretty in-depth case study here. So the situation for this plan sponsor is that the allowed PMPM costs for medical services are fairly stable. You can see that there's been a little bit of cost shifting to members over time. The plan paid amount has stayed pretty stable or even declined a little bit, while the member cost sharing piece has increased a bit. But overall, in aggregate, the costs have remained fairly stable over time. When we look at the next slide, we see that this plan sponsor's cost compared to other public sector purchasers was higher than most of their peers. So they had pretty stable costs, but costs that were on the high side relative to their other public sector peers. So in order to understand what's driving the higher costs, we can use the Health Partners total cost of care and resource use measures. Again, these are the same ones that we're using for public reporting at the practice group level. And really, this is an NQF endorsed methodology. It's reliability and validity tested. So if we know the total cost per member per month, and we also know the resource use, we can kind of back into the role that price and utilization each play in driving costs. So again, for those of you unfamiliar with resource use, it's a methodology that assigns a standardized weight or value to each medical service. Same on the pharmacy side as well. So every procedure code, every NDC code has a particular weight assigned to it, and that weight measures the relative intensity of the service or the resources that are used required to deliver the service. So we can add up all of the resources consumed by a plan sponsor and capture both the quantity and the intensity of resources that are used, and we can compare that to other plan sponsors. So by comparing employer ABC's cost and resource use to the coalition benchmark, we can begin to understand why their overall costs were high. So it may be the case that they are using more services for the same level of illness, and there may be several reasons for this. One might be that they have a generous benefit design that has lower levels of member cost sharing or limited financial barriers to utilize services. It may be that the population is receiving unnecessary or duplicative tests and procedures. It may also be the case that the population is using higher intensity services. So perhaps, an MRI or an X-ray would have accomplished the same diagnostic or provided the same type of diagnostic information. Or it could be the case that the population is paying more for the services that they are using. So this also could occur for several reasons. It might be that the beneficiaries of the plan are using an inefficient care setting. So maybe they're having an MRI in a hospital as opposed to having an MRI in a freestanding imaging center. It could be the case that the population has a benefit design with limited financial incentives for the members to compare prices among different providers. It could be the case that there's a concentration of members in a geographic area that has higher average prices for services, or they could be paying more for services due to unfavorable negotiated prices between carriers and providers. Or you could actually have the case where a given plan sponsor has both of these things going on at the same time. So they're actually using more services and they're paying more for the services that they're using. So when we looked at the data for this particular plan sponsor, what we found was that the allowed per member per month expenditure was about 6.8% above the coalition benchmark for medical services, and the resource use per member per month was about 5.2% above benchmark. So this is telling us that the higher overall cost is mainly a function of higher resource use. So this is really a good starting point, but we really need to know what type of resource use is higher and to try to determine the root cause. So in order to figure that out, we drill down to the next level. And here what we did was we looked at utilization rates by service category compared to the benchmark to gain some insight into what might be driving the overall resource use to be higher. So if we look at inpatient services, we can see that both on an admissions and a days per thousand basis, this particular plan sponsor was actually below the benchmark in terms of utilization. If we look at both outpatient and professional services, however, we see that both of those were areas where this plan sponsor was above the coalition benchmark in terms of utilization. And I included ER visits here as a subset of outpatient visits because that was an area where this plan sponsor exceeded the benchmark by almost 21%. So then we drilled further into the types of outpatient services, and we would do the same for professional, but in the interest of time, I'm just kind of going through the outpatient example here. So drill further into the types of outpatient services to see which types are overutilized compared to the benchmark. So this uses, I think, 8 or 9 different categories of different outpatient services. And we can see that this plan sponsor actually exceeds the benchmark utilization in all but 2 service types. And really what we did here was we focused on a couple of the service types where both the utilization in terms of the variance to benchmark was high, but also the amount of spend within that outpatient service type was also relatively high. So for this particular example, we really focused on emergency room because we can see that they were higher than the benchmark in terms of utilization, and emergency room services were accounting for about 7.5% of their total outpatient allowed spend. So when we drilled further into the ER utilization, here what we did was we looked at risk-adjusted emergency room rates compared to other public sector purchasers. And we overlaid that with information on benefit design and member cost sharing. And what we see is that this plan sponsor's rate of ER use is much higher despite having similar copays. And one thing to note here is that geography really doesn't explain the difference that we see in the levels of utilization either, because many of these public purchasers are really kind of dispersed throughout the state, as is this particular employer, ABC. So then we looked at ER visits by diagnosis, and we focused in on non-emergent ER visits. So these are diagnoses where you know, the ER visit results in an admission fewer than 5% of the time. So things like sore throat, cough and cold, headache, asthma and bronchitis, ear infections. So these are things, conditions where you know, care may be rendered in an alternative setting, such as a primary care office or an urgent care center, if available. So what we determined was, in talking with this plan sponsor, we determined that while the ER copay was in line with the other public sector plan sponsors, there was really nothing in their benefit design which would cause the member to distinguish between an ER and an urgent care center. So the copay for each of those places of service or sites of service was exactly the same to the member. So there was really no incentive for the member to seek out either an urgent care facility or perhaps call their provider to see if this might have been an issue that could have been taken care of in the office. So this is an example of how we can use the resource. Sorry, I think we're just having a little bit of a technical issue here. This is an example of how we can use the resource use and total cost of care measures to drill down and determine if cost or utilization or both are driving overall cost to be higher, and how benefit design might interact with each one of these pieces. All right, so the next section is really going to focus on pharmacy trends by plan sponsor over the same time period. And so we've kind of got the same layout here. We've got the first slide really looks at allowed per member per month spend by plan sponsor in year. Again, it's the data here is sorted by lowest to highest per member per month pharmacy spend in 2014, June of 2014. You can see that we don't have complete pharmacy claims data for all of the plan sponsors across all 4 time periods. So for those, that data has just been suppressed or omitted here. Again, we're looking at allowed expenditures. Yeah. So we're looking at allowed expenditures here, and which includes both the plan and the member paid amounts. So again, you can see here we've placed the book of business average on the slide as well as the MHGO average on the slide, and you can see that you can determine where your particular population falls with respect to each of those averages. On the next slide, we can see pharmacy resource use by plan sponsor in year. So here is where you might look by plan sponsor and determine if your particular population is well above the average on resource use. This is an indication that probably a lot of specialty utilization is occurring within your population. So we can see that that's the case for several of the plan sponsors over towards the right of the chart. And then on the last slide, again, we can calculate a price index by plan sponsor in year. So just a couple things to point out here. For example, plan sponsor O has seen quite a big increase over several of the last years in terms of the price it's paying for some of its drugs. And you can also see some of the plan sponsors towards the left of the chart are sort of in a more favorable pricing environment than those that are at the right of the chart. One other thing, just before we leave the pharmacy section, I did want to mention, you know, we have seen across several years of data that really what's been driving increases in pharmacy spend across plan sponsors has been increase in utilization of specialty drugs, so a lot of the biologicals, and also a big increase in price for those same drugs. And what we noticed when we looked into the data in the past year is that we have started to see an increase in the price of generic drugs as well. That's accelerating some of the pharmacy spend across plan sponsors. So this is kind of a new trend that surfaced in 2013 and persisted throughout 2014, so it'll be something to watch as we go forward. The last couple of slides are just on medical and pharmacy cost sharing by plan sponsor, and really what this tells us is when we look at in aggregate over time, members' cost share has increased for medical services but decreased for pharmacy services. And if you think about it, it kind of makes sense. Medical plans have been slowly introducing higher deductible plan offerings. On the pharmacy side, pharmacy tiers and the prices that go along with each tier tend to stay stable for several years at a time. And so while utilization increases or price increases, but the copay amount to the member stays flat, that's really the plan that's picking up the difference there. So the member share as a proportion of the total pharmacy spend has generally been decreasing, and we see just the opposite for medical services. In aggregate, we see member cost sharing has increased slightly since the first reporting period here. On the next slide, you can see the plan paid amount as a percent of the total allowed amount, again, by plan sponsor and year. This one looks specifically at medical services. We've put the book of business average on the slide, so this will allow you to easily identify if your particular plan is towards the right of the chart. Those are tend to be the more generous plan offerings where there is less member cost sharing. Plans toward the left end of the chart tend to be higher deductible plan offerings where there is more cost sharing placed on the member. So as a proportion of the total allowed amount, the plan is actually paying out less of that amount going to the provider. And finally, on the pharmacy side, very similar chart. This is just looking at what proportion of the total allowed amount for pharmacy is being paid out by the plan as opposed to by the members. So that's really all I had prepared. If you have, we are going to open up the line, I believe, to questions now. If you have additional questions, you can also feel free to contact me after. My email address is here for any questions. Feel free to reach out to me.
So if you have a question, please type it into the chat box on the menu bar on the side.
Okay, looks like we've got one question here for Sarah. Somebody asking if you could possibly provide an example of an employer that uses data analytics.
Sure. We do offer quite a bit of support to one data member in particular that has several, risk-type contracts with several different provider systems throughout the state. So in that instance, we help the plan sponsor to, monitor per member per month expenditures against a target that has been established with each of the provider systems. We help to select which population of members is actually going to be at risk in each of the contract years. We provide lists to the provider systems of those patients that are within the risk population. And we do a lot of in-depth analysis for the provider systems that are taking part in those ACO-type arrangements in order to provide insight into what's driving some of the costs and utilization within the population that they're managing.
Okay, great. We do have another question here, and again, if you have a question that you're thinking about, go ahead and put it in the chat box, but for now, we've got this one. Are there any data products that support patient management at the practice level? We do. That's another important part of the data program that I really didn't
talk about much today, but we do have practice reports that are available to all of the primary care practices in the state of Maine, and those really help different provider practices to understand how they compare to their peers in terms of cost and resource use and quality for a similar benchmark practice. We also have for the provider systems that are data members, we offer a portal into the plan sponsor data here, where provider members can actually see identified claims data for the members within any of these plans, or most of these plan sponsors that I've talked about today, included in the report, can see identified claims data for those members within the plan sponsors who have been attributed or enrolled to the providers within their system.
Okay, at this point, I don't have any more questions that are coming through the chat box, so I guess we had a very efficient timing on that. And again, you can access the slides for this webinar on our website, or email Sarah directly with any questions regarding the webinar, or myself regarding membership. So thank you so much for joining us today, and we hope you enjoy the rest of your afternoon.